Hi, Mike Gibson, Christian Spies, coming to you live from SCAI 2016, talking about TAVR. Obviously, Christian, TAVR has demonstrated its benefit in high-risk patients, but now there's a lot of emerging data for the intermediate-risk patients. Talk to us about where you see that going.
Well, as was nicely presented at ACC just about a month ago, we have pretty clear evidence that intermediate-risk patients are doing better with TAVR than with surgical aortic valve replacement. What this obviously means is that the patient pool who potentially can be considered for TAVR is significantly larger now. And with now already starting in the planning phase or already started low-risk trials, this will progress even further.
Sure. So if you had to guess, Christian, I mean, what kind of multiples more patients are there of intermediate risk than high risk?
It's a lot of discussion, at least twice as many, probably 3 times as many. The issue will be is that patients know about it, referring physicians know about it, so the actual increase in volume which a valve clinic will see will be even more than the actual patients who will qualify.
Right. So Christian, we have TAVR Tuesdays. Does that mean we're going to have TAVR Wednesdays, Thursdays, Fridays? I mean, is this going to be a every day of the week process now?
The short answer is yes, because we coincidentally also have TAVR Tuesdays, and we just extended to have TAVR Wednesdays. And the discussion is ultimately, do you, with the resources required, is your center planning on adding on a day or 3 preset days, or is it merging into a direction such as PCI, that one should be able to say, okay, I can schedule a TAVR tomorrow. Right. And I think that's still in a discussion right now. The majority of programs, including us, I think moves towards adding on a second day. We heard over the last year or so.
And by the way, these aren't technical issues. These are administration throughput issues and CT scans and how do you rev up the radiology department as well, right?
Yeah, it is. All of it is now upstream, so to speak.
Right.
We focused years ago, initially when it came down to doing TAVR on a day-by-day basis, daily practice, on the post-operative care, streamlining fast track, order sets, and so on and so forth. Then we moved into the perioperative area where we debated conscious sedation versus general anesthesia. Now we are really in the pre-procedural situation where we need to ask ourselves, how do we do all those TAVR evaluations? How do we negotiate with our radiologists block schedules for CT scans, for example?
Right.
And we started years ago with maybe 2 CT scans a week. We now do probably 2 CT scans almost every day.
Right.
And that has consequences for the scheduling in the radiology department, for the radiologists, for their interpretation. It's obviously a more timely CT scan to interpret.
And if you had to look into the future, Christian, I mean, with low-risk patients, what kind of multiple addition would that be? Do you have any sense?
It is estimated that with intermediate and high risk, we capture maybe 70-75% of the patient population. So that gives you an idea of what is out there once we deal with all comers with aortic stenosis.
So we're probably doing 20% of the population now, 20-25%. We'll move to 75% with intermediate and 100% with low. Interesting. Well, good to know that we've worked out the technical issues, but sometimes the administrative issues can be challenging, right?
Yes.
In hospitals. Christian, thanks for joining us today.
Thank you very much.
And thanks to all of you for joining us here live from SCAI 2016.